morning, students. Last class we have discussed about the odontogenic tumors, the tumors which are related to the oral cavity, mainly the ameloblastoma, which comprises of follicular ameloblastoma and plexiform ameloblastoma, adenomatoid odontogenic tumors, and CEOT, calcific epithelial odontogenesis, and it is also called as Pinberg's tumors. And today's class we are going, and last class we also discussed about adamantinoma. Now in this class we are going to discuss about the physical and chemical injuries of the oral cavity. It comprises of both the maxillary jaw and the mandibular jaw. And next thing what we are going to discuss today is about what are the fractures of the jaws, what is the classification of the fractures of the jaws. Coming to the injuries, these injuries may be either physical injuries or chemical injuries. Coming to the physical injuries, they may be iatrogenic, means where during the repair of the tooth or restoration of the missing tooth. See, during any repair, means due to caries or periodontal problems or due to any chipping out of the enamel, or where we need to place a restoration. Restoration is nothing but placement of a cement or placement of a composite material in the tooth structure, and filling the tooth is known as restoration. Or complete tooth replacement means either placing of a tooth crowns is called as restoration of the missing tooth. Next thing, self-inflicted means some people do vigorous brushing or overzealous tooth brushing, thinking that due to excessive tooth brushing, teeth becomes white. On overzealous oral hygiene practices caused by the psychotic or neurotic conditions or due to the habitual conditions. The third one is the trauma. This trauma may be due to a fall, a fight, or the accidents, or maybe due to the sports injuries. These are the different physical injuries. Coming to the chemical injuries, chemical injuries may be due to environmental elements such as the toxic levels of chemicals either in air, water, or in consumables. For example, we see that discoloration in a creamish or brownish color or yellowish color teeth in some individuals. People who consume more fluorine through water in some fluoride rich areas, there we observe yellowish or brownish color staining on the tooth. Some people who take tetracycline medication for a long periods of time also, we observe yellowish or brownish color discoloration on the tooth surface. Next, certain restorative materials which are used in the dental practice also cause certain discolorations of the tooth. I repeat, the environmental elements such as toxic levels of chemical in air, water causes discoloration. The second thing is the restorative materials used in the dental procedures. The physical injuries, either the bone injuries or the tooth injuries. Coming to the bone injuries, it causes fractures of the jaws, either maxilla or mandible. Next one is the orthodontic movement. What is orthodontic tooth movement? In some children or in the adolescent stage, we see proclination of the tooth. Maybe most commonly seen in the upper jaw, anterior teeth, we see proclination of the tooth. This proclination may be due to genetic factors or spacing due to the thumb sucking habit, or due to certain many factors are there which causes proclination of the teeth. So in order to give treatment to this proclined teeth, we give orthodontic treatment. People also call it as a wire treatment. So this is called as orthodontic tooth movement. Coming to the teeth, this is two types, either due to restorations or direct injury to the tooth. The restoration, how we restore a tooth, any cavity is there or any decay is there, first we need to remove the discoloration or decay, then we need to prepare a cavity. We need with the help of an aerator. Now I am going to show you what is an aorta. See, this is the upper jaw. This is the lower jaw. I am showing you both the upper jaw and the lower jaw. See, this instrument is called as an aorta. This instrument is called as an aorta. This, the tip of the instrument, which is I am showing you this point, is called as a burr. The type of burr used, okay, and the heat produced during this procedure, and the smear layer formed, and the vibrations caused during the operating of this instrument, and the last one is the acid etching. This is in brief about the preparation of the tooth cavity. Next one, according to the material, certain materials which are adhesive materials, glass ionomer cements, GAC, and non-adhesive amalgam materials. Next, direct injury to the tooth. It is caused by bruxism, ankylosis, and fractures of the tooth. The direct injury caused to the hard tissues is a traumatic bone cyst. Hope you all know what is traumatic bone cyst. The word itself, the name itself indicates it is due to the trauma to the bone which leads a cyst formation. So what is traumatic bone cyst? It is also called as solitary bone cyst or hemorrhagic bone cyst or simple bone cyst. Here, using this term cyst is a misnomer. Coming to the definition, it is an unusual, benign, empty or fluid-filled lesion which occurs both in the jaws as well as in both in the maxillary jaw and the mandibular jaw as well as any other bones in the skeleton. Understood? It is an unusual, benign, empty or fluid-filled lesion which occurs both in the jaws as well as in the other bones of the skeleton. It has no epithelial lining. Clinical features. The frequency of the occurrence of this jaw cyst is less than 1%. Age. Most commonly it occurs in the second decade of life. Mostly below 30 years of age only we observe this cyst. Gender predilection. It is equal in both males and females and shows a slight predilection towards the males. Site. Coming to the oral site, maxilla and the mandible. Mandible is more commonly affected compared with the maxilla. In the mandible, the buccal and lingual surfaces are more commonly affected compared to the lingual surface. Mandible. The body of the mandible and the symphysis is the most common site of occurrence. Coming to the maxilla, the anterior portion of the maxilla at the anterior region is the most common site of occurrence. Clinical presentation. A very low symptoms we can observe. A slight swelling which leads to pain and leads to labial paresthesia. Compared to this, there are very less symptoms. Thus, it is an accidental finding in a radiograph. There are very less symptoms, so the finding we can notice only in the radiographs. See, I think you can appreciate in this picture, the radiolucent area with the irregular but definite edge and slight cortication is seen, and the occlusal view, the radiolucent area extending along the cancellous bone. Okay. The cyst seen enveloping the roots of erupted teeth, and the lamina dura is prominently seen. Occasional root resorption is also seen. Okay, you can see in this picture, a clear radiolucency is appreciated here. The radiolucency is appreciated in the molar area, and it is a round or ovoid cavity. See, this is a round cavity, and it involves the vital tooth. Coming to the differential diagnosis, a static bone cavity usually lies below, and the traumatic cyst usually lies above it. It Etiology. The etiology is unknown, but the most common site is of occurrence is the trauma to the bone. Any type of trauma, either due to a fall or due to an injury, it causes trauma to the bone and it leads to intramedullary hemorrhage, which further leads to the failure of early organization of the hematoma and leads to subsequent liquefaction of the clot. Ultimately, it leads to traumatic cyst formation. These traumatic cysts, I've already told you, these are less than 1% of the chassis. Most commonly occurs in the mandible compared with the maxilla. Age predilection less in the second decade of life. In the mandible, it occurs in the body or symphysis region compared with the maxilla, and in the maxilla, it occurs in the anterior region. Subsequent degeneration of the clot is observed, and the hemolytic products accumulation leads to capillary fluid transudation and bone resorption. Slowly, pressure goes down and eventually producing an empty cavity within the bone. Pathology. Ultrastructurally, we can see the histopath picture reveals loose vascular fibrous tissue and it shows fragments of fibrin with enmeshed red cells, hemorrhage and hemosiderin pigment and scattered small multinucleate cells are observed. Treatment. The surgeon should open the cavity, treat it as a part of the diagnostic process. The cyst lumen and the cyst wall is curated. The granulation tissue and eventually new bone proliferate and replace this hemorrhage. Recurrence is unusual, but in some cases the recurrence also is reported. Next one is a ciliated cyst of maxilla. Epithelium of the sinus becomes entrapped along the line of surgical entry into the sinus and subsequently proliferates to form a true cystic cavity, anatomically separated from the sinus. Clinical features. Age. Middle-aged and the old age. Both the cases we see this occurrence. There is non-specific, poorly localized pain, tenderness or discomfort is observed in the maxilla. Swelling can be either extraoral or intraoral. Patient gives history of surgical procedure involving the maxilla and the maxillary sinus. Mucopycocele. Mucopyocele. When content of mucocele is infected, we call it as mucopyocele. Histologically, the walls of the cyst is composed of fibroid connective tissue with or without inflammatory cell infiltrate, and the treatment is enucleation. The first slide I have told you regarding the orthodontic tooth movement. When we are giving orthodontic treatment for the proclined teeth or teeth which are the maxillary teeth which are proclined towards or which are having a gap between each individual teeth, that is called as spacing, where there we give this orthodontic treatment. During this procedure, the ability of the teeth to be moved through the bone without their subsequent extrusion or loss by application of pressure or tension under appropriate and controlled circumstances. Means this procedure or this treatment lasts for a period of 1 year or 1.5 years, and slowly the wires will be tightened so that the proclination comes down and it will occlude with the maxillary teeth and mandibular teeth. During this procedure, we come across the mechanism, movement of the tooth. Mechanism, bone under pressure, this is called as resorbing. Bone under tension, this is called as deposition. There are different movements during this procedure. Some of the important movements are tipping movements, extrusive movements and intrusive movements. Movements, the degree of force, the direction of the force, the position of the fulcrum around which the force acts. These three are the important movements or the factors which influence the treatment of the proclined teeth. Coming to the tipping movement, from the pressure side, the compression of the periodontal ligament takes place which leads to the osteoclast migration to the site and which deposition of new spicules of bone on outer surface of labial plate, maintaining the thickness of already labial plate by preventing proliferation of the tooth, which further leads to ischemia and necrosis. This intrusive tooth movements, the tissue changes are opposite to that of the extrusion. The resorption of bone occurs at the apical area and around the alveolar margin. Here, the new bone formation is very minimal. Coming to the injuries of the teeth associated with the restorative procedures. What is the restorative procedure? Any procedure where a caries is noticed in the teeth and we need to remove the caries and fill the tooth with the material is called as restorative procedure. During preparation of the tooth for restoration or due to restorative material. These two are the two main causes. First one is during the preparation of the tooth for restoration. Second one is the due to restorative material. See, during preparation of the tooth for restoration, type of instruments used means the burr which we use, which is either steel burr, diamond burrs, or alternative cutting materials like an air abrasion. See, this is called as an aerator, where we use this instrument for removing the debris and cleaning the tooth cavity and preparation of the tooth cavity. The tip of the instrument where we keep this one is called as a burr. This may be either steel burrs or diamond burrs. Second one, thermal injury. See, during operating with this instrument, heat, this is electrically controlled machine, so it produces heat. It causes thermal injury. Third one is the pulp exposure. You all know the parts of a tooth, enamel, dentin, and the innermost one is the pulp. Pulp exposure, smear layer, vibrations caused, desiccation of dentin, and the acid etching procedures, and the remaining dental thickness. These are all effect on dentin and pulp depends upon these factors. Coming to the smear layer formation, this microscopic layer is formed after the tooth is cut and it is prepared. This is less than 2 microns in thickness. This consists of cutting debris from tooth and contamination from the oral cavity. Dentin and its parts, intertubular dentin, peritubular matrix mixed with water and the dentinal fluid. Occasionally, saliva along with the bacteria also causes a layer. This is beneficial because it flow of the fluid through the dentin, permeability, entry of bacteria, all it is controlled by the smear layer formation. The smear layer controls the flow of fluid through the dentin, the permeability and the entry of bacteria into the tooth. But this layer has to be removed to obtain optimal chemical and mechanical bonding between the restoration and the tooth structure. Understood? This layer is beneficial because it provides the flow of fluid through the dentin and the permeability and the entry of bacteria is restricted. But it has to be removed to obtain the optimal chemical and mechanical bonding between the restoration and the tooth structure. Heat. While operating this instrument, this is influenced by the size, shape, and the composition of the burr or the stone, the speed of the burr or stone, the amount and direction of pressure on the cutting instrument, the amount of moisture in the field of operation, the length of time the burr is in contact with the tooth, the type of tissue being cut, whether it is enamel or dentin. So, what are the effects of heat? The separation of the odontoblastic layer, edema, hyperemia, and inflammatory cell infiltration. In severe conditions, the pulp may develop blisters, abscess, or maybe in some cases the pulp is destroyed. See, you can see the aerator picture what I showed you here. You can see this picture in the slide also. Okay. Effects of high speed instrumentation. What happens if you use this instrument in a high speed? Definitely it generates a lot of heat. So producing heat, if this heat is naturally, it causes damage to the oral soft tissues. So what to do? Inadequate cooling or excessive drying of the dentin occurs after the cavity preparation. So this what happens? Displacement of the odontoblastic nuclei, disorganization of the organelles and nuclear membrane, and lysis of cellular elements takes place, which ultimately leads to the dead tracts formation. I repeat, inadequate cooling or excessive drying of the dentin occurs after the cavity preparation. So there is displacement of the odontoblastic nuclei, disorganization of the organelles and nuclear membrane, and the lysis of cellular elements. Ultimately, it leads to the dead tracts formation. So we need to give the adequate cooling to the instrument. Next, you know what are abrasives? So what are air abrasives? Aluminum oxide is sprayed under pressure for cavity preparation. Bulk irritant, imperfect sealing, pressure and heat is involved. Uses. This is used for a short period. The cleaning of small pit cavities and fissures, especially in the premolars and molars, where you have lot of cracks and fissures on the occlusal surface of the molars. Coming to the lasers. What is a laser? Laser is nothing but light amplification by stimulated emission of radiation. This is the full form of laser. Light amplification by stimulated emission of radiation. The uses of the laser is desensitization of the exposed root surfaces, roughening of hard tissues to promote bonding, vaporization of carious tissue and organic tissue in endodontic preparation. There are many uses of lasers, but the ultimate disadvantage of this is heat generation. Lot of heat is produced during the operation of the using of lasers. Thus lasers should be used with very care or caution. Next, ultrasonics. These also causes immediate reaction, mild hyperemia, slight lymphocytic infiltration. The late reaction is the calciotraumatic infiltrations. Next, reactions to restorative materials, tooth restorations, interfaces and adhesive techniques. I already told you what are restorative materials, direct restorations and indirect restorations. Coming to the direct restorations we come across amalgam, gold fillings and different types of cements. See, the dental amalgam and its proposed metallic alternatives. Condensable, condensable gold. Different cements and liners like zinc phosphate cement, silicate cement, temporary restorations which is used material is most commonly used material is ZOE. ZOE is called as zinc oxide eugenol. ZOE is called as zinc oxide eugenol. Coming to the indirect materials, these are resin based composites and the most common used materials is GIC, that is glass ionomer materials and resin modified glass ionomer cements. Coming to the direct restorations, amalgam, which is commonly used. Injury due to exothermic reaction, compaction pressure. Deep cavities are restored with amalgam. This decreases the number of odontoblasts, mild inflammatory cell infiltration, and extra pressure can directly expose to the pulp. Cements like zinc phosphate cement, they cause hyperemia, hemorrhage with inflammatory cell infiltration, and it reduces the size and number of the odontoblasts. Silicate cements, they cause mild to severe pulpitis. Zinc oxide eugenol. This is the most universal agreement that zinc oxide eugenol is least injurious of all the filling materials to the dental pulp. So this is most commonly used restorative material. It causes palliative and sedative effect on the mildly damaged pulp. So this zinc oxide eugenol is most commonly accepted and widely used. Resin-based materials. Phosphoric acid removes the smear layer and it demineralizes the dentin forming hybrid layer. Glass ionomer cements, advantage over silicate cements and zinc phosphate cement. So zinc glass ionomer cements are and the glass ionomer restorative materials are most commonly used. These are bland, moderate and less irritating to the pulpal tissues. The absence of strong acids and toxic monomers and presence of high molecular weight polymers. Coming to the physical injuries of the teeth. I already told you the physical injuries, bruxism, ankylosis and fractures. What is bruxism? Bruxism is nothing but grinding of teeth. In some individuals, we observe grinding of the tooth. Some people, this grinding is observed at night times. Means people, while they are sleep, they grind their teeth. This is called as bruxism. This is also called as night grinding or bruxomania. Bruxism is also called as night grinding or bruxomania. Definition. It is the habitual grinding of teeth either during sleep or as an unconscious habit during walking hours. I repeat, it is the habitual grinding of the teeth either during sleep or as an unconscious habit during walking hours. Habit. Both clenching habit and tapping of the teeth. So ultimately, which tissues are affected? The pressure is exerted on the teeth and periodontium by the actual grinding or clamping of the teeth. See here, if there is continuous grinding of the teeth, what happens? Which surface is affected most commonly? See, this is the upper jaw. This is the lower jaw. You can see, this is the upper jaw, this is the lower jaw. If there is continuous grinding of the teeth, like this, which surface of the tooth is affected? Naturally, the occlusal surface is the most commonly affected. Occlusal surface means this one. This surface is the occlusal surface. This one. This is the occlusal surface. So, we give night guards or an instrument or a protective layer on the occlusal surface of the upper and the occlusal surface of the lower teeth. So, due to the continuous night grinding, what is the etiology? It may be local factors, systemic factors, psychological factors, and occupational factors. Local factors generally associated with some form of mild occlusal disturbance, which produces mild discomfort and chronic tension. In children, the habit is generally associated with the transition. What is the transition period in children? See, there are two sets of teeth. One is the primary dentition and the other one is the permanent or the adult dentition. The primary teeth are also called as milk teeth or deciduous teeth. See, when the primary teeth are shedding and the permanent teeth are coming, means the permanent teeth are erupting, the middle phase is called as a transition period. The period where the primary teeth are shedding off and the eruption of the permanent teeth takes place. This period is called as a transition period. During this period, the children may result from an unconscious attempt to place the individual tooth planes so that musculatures will be at rest. And Coming to the systemic factors, some factors like gastrointestinal disturbances, subclinical nutritional deficiencies, allergies, endocrine disturbances have all been reported as causative factors. Cases of acrodynia, psychological factors are also believed to be the most common cause of bruxism. Emotional tension may be expressed through a number of nervous habits, one of which may be bruxism. Thus, when a person suffers from fear, rage, rejection, or a variety of other emotions which he is unable to express, these become hidden in the subconscious but are expressed periodically by numerous means. Bruxism is common in mental institutions, also seen in nervous tension in children, and may be related to chronic biting or chewing of the toys. Certain occupations. Athletes engaged in physical activities often develop bruxism. Voluntary bruxism is also recognized in those persons who habitually chew gum, tobacco products or objects like toothpicks or pencils. Although voluntary, this too is nervous reaction may lead eventually to involuntary or subconscious bruxism. Occupations in which the work must be unusual, precise, such as that of the watchmakers, are also prone to cause bruxism. See, people having the habit of holding the pencil or pen or any instrument with their teeth. Some occupations like watchmakers or who do precise or who do microscopically who observe anything. In all these occupations, we observe bruxism. Next, typical grinding or clenching motions during the sleep. The effects of this have been divided into 6 categories. The effects on the periodontium, the effects on the dentition, affecting the masticatory muscles, affecting the temporomandibular joint, head pain, psychological and the behavioral effects. See, ultimately, if there is continuous grinding of the tooth, what will happen? Definitely, we observe cracks on the tooth, further chipping of the enamel surface and flattening or worn down of the tooth surface takes place. This is what ultimately it leads to due to the bruxism. Understood? Next, severe wearing of the tooth surface. You can see this picture. See this one. So, what is the treatment for this? If the underlying cause is an emotional one, the nervous factor must be corrected if the disease is to be cured. Removable splints to be worn at night may be constructed to immobilize the jaws or to guide the movement so that periodontal damage is minimal. The use of oral sensors to have developed bruxism patients. So this is what we give to the patients who complain of bruxism. The outer layer is hard and is durable, and the inner layer is soft and it rests comfortably against the teeth and the gums. Okay. Now, coming to the injuries to the or fractures of the teeth. The fractures of the teeth are caused most commonly due to the trauma. And the most common classification of the tooth fractures is the Ellis classification, which gives in class 1 to class 9. This is Ellis classification. Depending upon the involvement, we classify them as class 1 to class 9. Class 1, simple fractures of the crown. See, I repeat, you all know the parts of a tooth: enamel, dentine, pulp, all these parts. So if you can remember the parts of a tooth, you can easily remember this Ellis classification of fractures. Class 1, simple fracture of crown. Here the enamel fracture involving, but there is little or no involvement of the dentin. See, class 1 simple fracture of crown where there is little or no involvement of the dentin. Class 2 extensive fracture of the crown. Here considerable dentin fracture is seen, but there is no pulpal involvement. Class 3 extensive crown fracture. Here the enamel and dentin are involved and causing pulpal exposure. Class 4 traumatized tooth becomes non-vital with or without loss of crown structure. Understood? In the class 4 traumatized tooth becomes non-vital with or without loss of crown structure. Class 5 tooth is lost due to the trauma. Class 6 here we see root fractures with or without loss of crown structure. Here the crown structure may be or may not be fractured, but there is the fracture of the root. Class 7 displacement of tooth with fracture of crown or fracture of root. Class 8 the fracture of crown en masse and its replacement. Class 9 traumatic injuries to the deciduous tooth. Understood? This is the classification of the fractures of teeth. This is given as class 1 to class 9. Different clinical pictures showing the tooth fractures. This is crown is intact, whereas the root fracture is appreciated in this picture. Clinical features. If there is crown fracture without pulp involvement, tooth remains vital but may have mild pulp hyperemia. If the tooth remains vital, secondary dentin formation is observed, but tooth may be sore and slightly mobile because of the injury. The treatment is pulpotomy or pulpectomy may often be necessary as infection sets in as soon as there is pulpal exposure. Thank you.